Good afternoon, everybody. So welcome back to the third session of the APLC, which is dedicated to chronic lymphocytic leukemia or CLL. So I'm Eric Jie from Hong Kong, and sitting next to me is Professor Loretta Novoseltsova from Chiang. So I would let Loretta to introduce our first speaker of today.
And for today, it's an honor to introduce Professor Stephen Mulligans. Professor Mulligans is a clinical and laboratory hematologist with current appointments as senior staff specialist hematologist at Royal North Shore Hospital. He's the adjunct professor at Faculty of Medicine, University of Sydney. He's also the director of hematology and flow cytometry at Helios Pathology, Sydney. Professor Mulligans has had a career-long interest in CLL. He continues ongoing CLL-related clinical trials and laboratory research at Royal North Shores Hospital and University of Sydney. He's a founder and president of the CLL Australian Research Consortium, aimed at fostering CLL research in Australia and the regions. And everyone, please welcome Professor Mulligans.
Firstly, thank you very much, Eric, Lolita, Yaute, and the organising committee for asking me to speak and inviting me here to Chiang Mai. So I'm going to talk about CLL with a particular focus on frontline therapy, and particularly whether or not, or rather the pros and cons and the many trials for continuous, fixed duration, and now potentially emerging MRD-driven therapy. Now, this is the brief history of CLL. We haven't gone back to 1928 for the first publication by Minnow and Isaacs introducing radiotherapy, but it was then 25 years later that Everett et al. Produced chlorambucil. It was almost immediately put into use by David Galton and William Damashek in the UK and the US respectively, and we're still using it to a minor extent. 35 years went by before we got fludarabine, and then another 25 before we got novel therapies or targeted therapies, and that's largely what I'll focus. So we can conveniently divide treatment for CLL into the essentially immunochemotherapy era, with basically a slow progression until we got FCR, which was really the actual true first major advance in terms of PFS. And now, of course, we're in this enormous transition to targeted therapy. Initially with BTKIs, BCL2Is that came out at much the same time, but then a 2 or 3 year delay with the TLS problem with venetoclax. And of course, now it's mainly focused on combination therapy. So because the first of these to come out was the paradigm of continuous therapy with Bruton tyrosine kinase inhibition, that's remained the paradigm for the utilisation of those particular group of drugs that we've got available at the moment. With the introduction of venetoclax, we've started using predominantly fixed duration therapy. And of course, historically, immunochemotherapy is fixed duration therapy. And then I'll touch on more briefly the MRD-directed therapy that's largely piggybacking off the FLAIR study, part 2. Just as a recap, can we cure CLL? Yes, we can. Half of those patients that have got mutated immunoglobulin genes are curable with FCR. That's been demonstrated both with the original FCR 300 group from MD Anderson, Germans, the Italians, we have also in Australia. Phil Thompson's just done this update that was published at the end of last year that's now just a smidgen under 20 years of follow-up, and still you've got half of the patients that have got mutated immunoglobulin genes still in complete remission. And in the top graph, you can see that the little tiny black line there is age-matched controls from the US for which it overlaps. However, most of the data from FCR is in younger patients, as in less than 65, 70. Half of them are cured. That's a big ticket item. Remember, that's half of the mutateds, which are about a third of patients that require treatment. So we're curing 15% with that. But if you use full dose, you certainly get prolonged cytopenias in some, opportunistic infections in some of those. And if you've got complex cytogenetics, then you've got the problem of clonal evolution, and that's unequivocally a problem, particularly in those with 17p deletion and or TP53 aberrancy, in whom immunochemotherapy is and should be absolutely contraindicated because of that problem. There's the 2% AML risk, which everyone quotes as why they're not using it anymore, but there has been an almost universal change away from immunochemotherapy to targeted therapies, which basically target the signalling mechanism from the top end, if I can refer to it in that way, and unblocking the apoptotic pathway at the other end with BCL2 inhibition, with ibrutinib as the paradigm and venetoclax respectively. So let's take a look at the data from continuous monotherapy. As you will know, we've got 3 covalent BTK inhibitors, namely ibrutinib, acalabrutinib, and zanubrutinib, that are widely available. The ibrutinib data is demonstrated here, namely the RESONATE study comparing it with chlorambucil. Even at the time of trial design, we knew that was going to be an unequivocally inferior therapy. The Alliance study published by Jennifer Woyak and colleagues, the top 2 lines are ibrutinib and with and without rituximab, the CD20 monoclonal antibody, versus the green in BR. BR is universally the inferior arm in every study in which it's ever been conducted. But it does also highlight that the addition of R to I makes absolutely 0 difference whatsoever, as Jan Berger had demonstrated in an earlier trial as well. And then we've got the ECRIN study that was run and published by Tate Scharnefeld, comparing IR versus FCR with a 2-to-1 randomization. Now, this is the long-term follow-up that was presented by the RESONATE 2 group at EHA, and Sue O'Brien presented this at the ERIC CLL meeting in Barcelona just recently. And thank you to Susan for all of these slides. And thank you in turn to Nitin Jain from the MD Anderson, who I understand from Susan provided most of the slides to her. However, what you can see is that you've got just a smidgen under 50% of those patients still in PFS at the 10-year mark. What we knew right from the early times of both RESONATE, i.e. relapsed refractory, and also RESONATE 2, i.e. the front line, is that mutational status with ibrutinib makes absolutely 0 difference whatsoever. And you'll note that it does with chlorambucil, as it did with, and it was, as we'll see again, with FCR. And indeed, moving on to that at the moment, this is part 1 of the FLAIR study that was run by Pete Hillman. Many of you will know that this started off as FCR versus IR. They got almost to the point of complete recruitment of the study, and then decided to extend it for another, doubling the patient number, adding in the 2 additional arms at the right, namely ibrutinib monotherapy and ibrutinib plus venetoclax. But the part 1 study comparing IR versus FCR is illustrated here with the progression-free survival, and you can see the striking difference. But equally strikingly, on the right-hand side of the slide, 0 difference if you're mutated. So 6 months of FCR has got the same outcome as continuous ibrutinib. but a very striking difference if you've got unmutated immunoglobulin gene, and no difference in overall survival. The other issue that was a concern when this data first came out is that we knew about the AML MDS risk with FCR, as you can see with the highlighted figure 3 on the left. But what this drove home very strongly at that time was the cardiac risk with ibrutinib. Now, there'd been a bit of talk about this in the earlier CLL studies, but this really drove that message home quite starkly, that 9 of their 30 deaths were due to ventricular arrhythmias and sudden death. To cut a long story short, the fundamental reason for that's never been all that clear, and as we'll see a little bit further down the track, part 2 of the FLAIR study, that has not persisted. The reasons for which neither Pete Hillman, Tala Munir, or anyone else has been able to fully explain at the present time. So if we look at ibrutinib in frontline studies, it's better than time-limited FCR, at least in the unmutated. Everything's better than bendamustine, and likewise, everything's better than chlorambucil. The main benefit being, as we've seen in the unmutated, and we've had the emergence and persistence of the cardiac signal with both arrhythmias, sudden death, and to a lesser extent, cardiac failure. As everyone in the room will know, there's also a bleeding effect that's in fact an on-target effect with BTK in the signal pathway of GP9 of the platelets, and the others as highlighted on the slide. So that's the basic data with ibrutinib as frontline. Let's take a look at acalabrutinib. Acalabrutinib, as was Xanu, were developed to be more specific, to hopefully try and lose some of these what might have been off BTK but on tech kinase targeting from ibrutinib. And so this trial was designed to compare acala plus obinutuzumab versus acala alone, and then chlorambucil plus O. And of course, both of the acala BTK arms were, as expected, strikingly better than the chlorambucil arm. But I guess what hadn't really been anticipated was that there turned out to be in fact, significant difference with acala with and without the addition of obinutuzumab. Now, again, we don't really know why, but this is probably, I think a lot of us believe, due to the slightly weaker and the requirement for a BD dose, but it's still not completely clear what the rationale, but that certainly has persisted. These are the CR rates, and remember, if you look hard enough, particularly for the first couple of years, with BTK inhibition, largely we don't cure CLL. You can almost always find a clone identified in the peripheral blood, let alone anywhere else. Again, if you look at mutational status, there's not much difference between them, but is there something emerging? Not quite entirely clear, but also surprisingly, there has turned out to be a modest OS difference between them as well. And Matt Davids will be presenting the triplet combination at ASH in a couple of weeks' time. So that's ibrutinib and acala. Let's take a look at Xanu in the front line. This trial, the Sequoia trial, compared in a randomized sense those without TP53 aberrancy, Xanu versus the invariably inferior BR, and for those with TP53 aberrancy, Xanu and another arm added a little later with venetoclax. And not unexpectedly, Xanu's performed the superior with PFS. And if you look at the mutated versus unmutated, again, it's a bit like the acala curves. Is there a difference emerging? Hard to tell. We'll have to look at the follow-up data, but no OS difference, at least without. So these are the kind of the headline PFS results at those years, slightly higher with the acalabina and the Xanu, with the Xanu being a slightly shorter time frame at that point. So let's take a look at venetoclax-based regimens. And since the very earliest study that encountered the TLS, virtually all of these since the time of Morano in the relapsed refractory setting have been fixed duration. And as we're increasingly doing, looking at both or different durations and whether we're using doublets or triplets. Now, this is the 6-year data on the CLL14 study. Those of you that follow blood obsessively will know that 2 days ago, Offman has updated this, and there's the publication on the 6-year follow-up in the blood publication of 2 days ago with accompanying editorial. What was nice about this study that hadn't occurred with the prior ones was that they matched the timing of the key drug and the obinutuzumab, both of them for 6 months and then an additional of 6 cycles with the active drug, and matched it with chlorambucil. And this is the 6-year PFS. Here it is with and without, with mutated versus unmutated. Now, as you can see, that's 6 years. If you look at the FCR data, it's after 8 years that it developed a plateau. Is that top line going to plateau with a cure fraction? We don't know. But when we look at the Gaia CLL13 study, this is the 4-year follow-up. As you know, this is looking at the triplets and doublets. This is the efficacy with the higher efficacy slightly with the triplet, but a slightly higher adverse event profile compared to the doublets, but the doublet being with obinutuzumab being better than matching venetoclax with rituximab, and both being superior to the 2 different chemotherapy regimens, i.e. FCR or BR. Now, what was nicely demonstrated in their cytogenetics is that there is a tiny cure fraction in that tiny 2% population of patients that have got the so-called triple trisomy. So if you've got trisomy 12, with or without trisomy 18 and or 19, we already knew that 100% of those patients were cured with FCR. It's now evident from their data that 100% of those patients are cured with venetoclax-based regimen. So in the front line, VG is better than chlorambucil and also FCR, although the direct comparison of crystallo will be also presented at ASH this year. The tumor lysis syndrome, not just delayed development, but I think all of us have probably had a hassle actually getting those patients with a high white cell count actually into a bed to treat them for their TLS prophylaxis, and that's remained a bit of a barrier to its use. And furthermore, the TP53 aberrants don't do as well if you follow them for more than a couple of years. And in fact, when you look at the 5-year PFS, it's actually not quite as good. But nevertheless, all of these are really good, effective, and largely pretty well tolerated therapies. So let's have a look at the doublet, triplet, monotherapy question a little bit, because most of the data emerging over the last couple of years has been focused very much on doublets and increasingly on triplets. Here's Nitin, who certainly provided this slide because it's his study comparing I plus V. But unlike the 2 of the other studies comparing I plus V that have gone for 3-month lead-in with ibrutinib and then 12 months of combination, this is 24 months of combination. And as you can see, both in blood and in marrow, if the longer you treat, the higher the proportion of patients that you get into MRD negativity, both in blood and in marrow. And that's going to be an important theme when we get to flare in a couple of slides' time. Now, when you're using it for that period of time, i.e. 2 years, that's pretty respectable PFS and overall survival. Again, no difference in this study at least, whether you're TP53 aberrant or mutated. And these are the comparative studies. I won't dwell on this, but show you again the largest table in a moment, just because the Captivate study has been presented this year by Bill Weirder at the 5 years, and intriguingly, there is a difference between mutated and unmutated, and at the moment, we're not entirely clear why there's a divergence between these trials with the mutated versus unmutated patient group. And what may well turn out to be a difference in overall survival irrespective of genetics. So here's the theme I was coming to, namely, the longer you use I plus V combo, the better it looks like your outcome ends up being. So let's look at the data where it's been used longer. Now, the FLARE study part 1, what we've touched on already, big difference, entirely present in, well, but not much in overall survival, but entirely coming from the outcome in the unmutated rather than the mutated patients. And in fact, in that study, they've ended up using it for a median of about 3 to 4 years so far. And so when you're now using, if you look at the last 3 lines, the MD Anderson for 2, Captivate for 1, and now FLARE for an average of, at least here, of 3, you're going from 80 to 86 to 94% PFS at approximately the 5-year mark. And here's that data in graphical form. Now, the GLOW study was targeting patients who were comorbid, and indeed some of them, if you look at the supplementary data, were very, very, very comorbid. And in fact, many of us in this room, I don't think, would have treated some of them. Nevertheless, this has resulted in approval, at least in Australia, for the I plus V as of the beginning of October. Now, the dramatic drop in the chlorambucil curve is an artifact of the fact that the drugs were stopped 6 months earlier, and then they mandated a 15-month CT scan. So that's why there's that big difference. But not as good an outcome in the elderly comorbid group. And again, we're seeing a little bit of difference whether you're mutated versus unmutated compared to some of the other studies. Now, the unusual overall survival curve here, where the I plus V do worse at the beginning, a bit difficult, but some of those patients were very comorbid, and it's probably the cardiac events that terminated their survival in the earlier phase, but has then changed as for the survivors, it's offered better CLL control. So GLOW, shorter period of time, but despite the fact that this is an elderly, pretty comorbid group, they've actually got, at least in the mutated, it's a pretty good outcome, although quite clearly the unmutated, it's not quite so good. Now, I won't dwell on these. Amplify, we think, is going to be presented at ASH coming up shortly this year, comparing ICT doublet versus triplet. But I thought I would put in this slide that Kerry Rogers presented at EHA in Madrid, largely to highlight the fact that this has been going for a while, so she's got 7 years of follow-up, not wanting to focus on the relapsed refractory, but if you focus on the purple line, you'll see that there does not appear to be a plateau, at least with the patients that are reaching that 6-7 year follow-up in the tumor-naive patient Now, there appears to be a slightly increased risk of second malignancies and infections, particularly with the triplets rather than doublets. As you're aware, there's now what appears to be, to the surprise of some of us, what appears to be almost an entirely new class of drugs, namely the non-covalent BTK inhibitors, of which Perto is the only one that's really been studied to any significant extent, with nemtabrutinib being the other one that's going into clinical trials. And again, this trial is also by the MD Anderson group, fairly early, and again, this theme of the longer you treat, the better the outcome. I've only put this relapsed refractory just to highlight the sonrotoclax, which has been developed by BeiGene, which is both a much more potent BCL2 inhibitor that will also block patients that have got the glycine valine 101 mutation that stops venetoclax working, but sonrotoclax is still effective, but early days with follow-up. And I won't dwell on the MRD here, but rather move on to the MRD-directed therapy. Now, many of you will know that Pete Hillman presented this data at ASH last year. This is the part 2 of the FLAIR study that was an adaptive clinical trial run broadly in district general hospitals across the UK. And the proposal or the premise for this is that treat the patients with the IV plus combination until they reach MRD negativity. And although this looks like a fairly complicated slide, you continue until you get MRD negativity and then double the duration on the premise that that will get you down to potentially either a very low or no CLL count, potentially in the potential range. Fairly typical demographics in the mid-60s for both arms. And the key data is that if you continue I plus B in combination, by just over 2 years, 27 months, you get half of them into MRD negativity, roughly 2/3, precisely 63% at 39 months, and almost 3/4, i.e. 72%, at 51 months. And perhaps counterintuitively, but not really with the biology of the disease, you get more of the unmutateds than the mutateds into MRD negativity. And we've seen these outcomes, but to highlight that figure of 97.2% is the highest PFS value ever obtained in a CLL study. A little bit of a difference in the overall survival. And as we saw in part 1 of FLAIR, it's almost entirely due to the unmutateds. Interestingly, when we had immunochemotherapy, ATM was considered an adverse prognostic marker, and here, at least to date, you can see that they've got a 100% cure rate, with the other subtypes also doing pretty well. And here is the data with the cardiac, and as you can see, the cardiac disorders, it's accounting for 10%, but the mortality rate is much lower at largely comparable to the FCR data. Now, I know that's been quite a lot of data because we've got an enormous number of trials. Those of you with the joy of going to ASH will encounter even more of them in a couple of weeks' time. And I think at least in some environments, the MRD-directed therapy is clearly achieving a better outcome. There's been a little bit of debate in the CLL community in different national environments about how easily that may or may not be implementable, largely dependent on your access to high-quality MRD capable of achieving MRD at the 10 to the minus 6 level. I will finish there.
Can we invite Professor Mulligan to be with us here? And then may I invite all the panelists to be with us on the stage. Professor Go Cheng from National Taiwan University, Professor Xiu Lu Gui from Chinese Science Academy, Beijing, and Professor B. Ping Chong from Malaysia University.
I think we can do the polling questions first. So we have a few polling questions that we want to see if the audience can actually vote using the website that you actually can find the QR code on your table. So the first question is, in CLL, when do you use chemoimmunotherapy? 1, a majority of patients. 2, a minority of patients. 3, only those with mutated IGHB. Or 4, I don't use chemotherapy at all. So please vote. 50-50. Oops. Let's see the changes. Yeah, I think probably because of in this region, because of the resource implications, so majority of us still use chemoimmunotherapy because the targeted agents, BTK inhibitors, and also venetoclax in combination with anti-CD20 antibodies are actually quite expensive compared to chemo. So let's go to the next question. So question number 2. Which BTK inhibitor do you mainly use? As Professor Mulligan has alluded to, right now we have 3 BTK inhibitors in the market: ibrutinib, acalabrutinib, and zanubrutinib. So which one do you use mainly, either in the frontline setting or in the relapsed refractory setting? 1 is ibrutinib, 2 is acalabrutinib, 3 is acalabrutinib together with the second generation anti-CD20 antibody obinutuzumab, or 4 zanubrutinib, or I don't use BTK at all. Yes. Yeah. I think people mainly use monotherapy ibrutinib. Maybe Stephen, would you like to comment on that?
So, I mean, this is interesting in the sense of, if you look at the late CN study, the data is very, very clearly in favour of the combination with map. Thank you very much. Hopefully my voice was loud enough to carry anyway. But there are certainly both logistic and the infusion reactions that are a not insignificant issue with obinutuzumab that does put a little bit of a barrier on its utilisation.
And I also believe that the differences in the use of different BTK inhibitors may be due to access issue, whether the drugs are actually available in their own sort of countries. So maybe perhaps in this particular, for this particular question, maybe I ask the panelists to comment on the use of the 3 different BTK inhibitors in your own countries. Perhaps maybe Professor Ko?
In Taiwan, both the 3 BTK inhibitor has been reimbursed only in TP53 mutated CLL. Acalabrutinib can be reimbursed on the first line, and ibrutinib should be on the second line. And zanubrutinib is on the way to get reimbursed. So in Taiwan, in case of a CLL, acalabrutinib may be the predominant, but in the future it may be changed.
What happened in mainland China, Professor Koo?
Yeah, in mainland China, we have 4 BTK inhibitors. ibrutinib and zamrutinib had the first line indication for CLL, and the other two, acalabrutinib and abrutinib, has only the second line indication for CLL. Yeah. So right now, mostly most of the Chinese physician will choose zamrutinib as a recommendation for patients.
What about the situation in Malaysia, Yiping?
I think we have BTKI in Asia. Yeah, I think, but my center, I think we have very limited experience in using because of the cost. I think my colleagues in private, they are using.
So the situation in Hong Kong is that for the first two BTK inhibitors, ibrutinib and acalabrutinib, they are both reimbursed by the government for both in the frontline setting as well as relapse refractory setting. Zanubrutinib came a little bit later, so I think right now we are still mainly using ibrutinib and acalabrutinib. And perhaps because of the side effect profile issue, people tend to use acalabrutinib a little bit more as well. Sorry? More than ibrutinib. So what about in Thailand?
Okay, we got 3, but Sanu just got licensed a couple months ago. So mainly patients on ibrutinib and acalabrutinib. However, none is reimbursable. So most of the time the patient pay or got insurance to get these BTK inhibitors, and many of our patients got that from clinical trials as well. Yeah.
So Stephen, what about Australia or your personal preference?
Let's just stick within Australia for the moment. Acala and Xanu became available for frontline therapy on the 1st of September last year. They're all 3 available for relapsed and refractory, but on the 1st of October, i.e. 1 month ago, I+V became available, and it's a bit difficult to gauge what the interest and level of uptake, but I suspect it might be a popular option, but VO is also available and is probably reasonably entrenched in that setting. Probably also worth mentioning, Jennifer Brown has presented the Alpine slightly extended update at the European summer meetings, and that's going to be published in ASH shortly as well. Sorry, in Blood.
Right. So next question. Yes. So the next question is, with targeted therapies, I prefer to use which of the following? 1, continuous therapy with a BTKI, or a fixed duration therapy, which is venetoclax based together with an anti-CD20 antibodies, or other novel treatment. It's actually interesting to see majority actually offer fixed duration therapy. So perhaps again at this point, maybe I can ask for opinion from, say, Stephen. What's your opinion?
Look, I'm not surprised because one on the left with continuous BTK because of the cost factor for those situations where it's not necessarily reimbursed, but I suspect that the center curve of is dominated by VO, for which we've now had 6 years of follow-up that Othman's just presented and published. Look, it's they're all good options.
What about situation in Taiwan? Which one do you usually prefer?
Because in Taiwan, both BTKI and the BCL2 inhibitor has only reimbursed with a limited time period, 24 months. So maybe I would like to prefer BCL2 at the
Right, so in Taiwan, also the fixed duration therapy. Okay. What about in the mainland?
So right now, the venetoclax has not the indication for CLL. So we prefer the fixed duration therapy with BTK inhibitor combination with immunochemotherapy.
Okay. What about in Malaysia?
I think Malaysia is the doctors, but personally I prefer BCL2 inhibitor because you can stop it after that. Yeah, cost-wise also it's cheaper.
Well, in Hong Kong, because venetoclax is not reimbursed by the government, so at least for the frontline setting, I think most of us actually use BTK inhibitors, which in most circumstances are actually reimbursed by the government. So we tend to use BTK inhibitors more, at least in the frontline setting.
Okay, so I prefer fixed duration of treatment as well. However, we don't have commercial available venetoclax in Thailand, so it's our option. We can obtain venetoclax from outsourced from other countries, but not commercial available in countries. So fixed duration might not be exactly an option for Thai. However, I have some questions. So is this applying to patients with 17p mutation or with TP53 mutation? Would you give the fixed duration of treatment as well?
So, Lolita, that's a good question for which there's no uniform answer. Now, as you've seen from the data, if you've got 17p dysfunction, you don't do as well with venetoclax regimens as you do with BTK. But then there's the, on the other side of the coin, there's the question of cardiac disease, and if you've got someone that is fragile from a cardiac comorbidity perspective, or they've got bleeding propensity, then you still get not a bad response out of TP53 mutated patients. However, when they fail, you've then got the dilemma of what to do with them.
Right, so let's go to other questions. See some of the more specific sort of choices that you may consider. So the question is, what's your preferred treatment of choice for a 75-year-old patient with newly diagnosed CLL? IGH3 was unmutated and there was no TP53 gene aberrations, i.e. no TP53 gene mutation nor deletions in P, and the patient was physically fit. So here are the options. A, BR for 6 cycles. Obinutuzumab with carambacil for 6 cycles. Or BTK inhibitor single agent continuously. Or venetoclax plus first generation anti-CD20 antibodies for 1 year. Or venetoclax with second generation anti-CD20 antibodies for 1 year. So you can start to vote. That's interesting, very interesting, because for the previous question, we see more fixed duration than continuous treatment. Now we are seeing the other way around. So perhaps we can start with the Professor B. What's your opinion? What's your preferred choice of treatment?
I still prefer fixed duration. Yeah, I haven't changed my mind. Yeah.
So my opinion depends on the risk and also the age and the performance. For older patients, we prefer the one single BTK inhibitor for continuous use. But for younger patients, we prefer to do the BTK combination with immunochemotherapy for fixed duration. We have launched several studies. It shows the BTK inhibitor, such as we mostly use the zamblitinib with BR or FCR, we can get very high completion remission rate and can stop the treatment in 2 years. And after the stop using the BTK, no patient relapsed after now.
What about in your preference, Professor Go?
Personally, I prefer a fixed duration treatment, but in Taiwan, actually, these cases is not reimbursed with any target agent. So I finally choose chemoimmunotherapy.
That's right. Because same in Hong Kong, for this particular individual who has unmutated IgA3 and also no TP53 aberration, none of these new agents are reimbursed in Hong Kong. So we probably have to rely back on the old chemoimmunotherapy, unfortunately.
But I think the other thing that's interesting about the slide responses is that it reflects the ease of utilization. So you've got a fit 75-year-old, no cardiac morbidities, not TP53, so there's no distractors, and you give them a BTK and set and forget. So, I mean, really, you could say, here, take these tablets and come back in 6 months. I mean, we all follow them up more frequently than that. But really, if they don't get, if they're not 5% of people that get AF, they get spectacularly good disease control. The lymph nodes have gone in a week. The spleen's gone in 3 to 4 weeks, and they normalise their counts in 6 months. Whereas if you've got someone with over the threshold, and let's face it, anyone that needs treatment for CLL has got a lymphocyte count over 25. And most of them have got a nodal mass over 5 centimeters. So then you've got to deal with the obinutuzumab infusion reactions. They shake and bake for a day at least. And you've then still probably got to ramp up with TLS prophylaxis. So I suspect that that's what's the driving force behind the higher utilization of set and forget BTK.
Yeah. Yes.
Actually, I wasn't going to comment on this, but I can't resist myself. I was going to take a break. So the audience and the poll is like a little bit schizophrenic, because everyone says they really want a fixed duration, but yet when you go down and deal with it, everybody chose continuous. And even for China, it's quite disturbing that they have used venetoclax and chemotherapy and all this weird stuff. And also access to drugs. It's also surprising that a lot of AbbVie is not around for a long time in many of the countries. Not available, so they don't even have I plus V, not even to say VAN-O, you see. So I guess later when we have the industry engagement session, AbbVie is not joining us. I don't know why, but no pressure. Those of you who know AbbVie, but I guess the alternative Beijing will be here, and we can actually ask them how their BCL2 inhibitor is coming, and maybe part of the aim is to actually get access to all these drugs available and more choices for our people. So we actually want combination fixed duration, but yet we can't because we don't have venetoclax, we don't have all these other agents, which is part of the aim of the consortium, is to actually get access to the drugs, talk and work in collaboration with the industry. That's why the engagement session. So maybe we can talk to them. So in the Q&A later with Beijing, we can ask them whether they can bring. And we don't know why AbbVie has decided not to market venetoclax in quite a lot of countries. And even if it is, it's still very limited, which is very surprising.
Yeah. The other interesting point on that sort of polling results is that some people, actually 17% of people, tend to use the fixed duration treatment with venetoclax together with rituximab, whereas only slightly higher proportion using the venetoclax with obinutuzumab combination. And it's been shown actually in the CLL13 study that VO is much better than VR. I don't know whether it's because of the cost issue, mainly the cost issue, and also the
could be
infusion reaction is.
Or they don't have Obin. Is
Okay.
Roche around? I think Obin is quite available, right?
I think, well, at least in Hong Kong it's available. Thailand, Taiwan.
So it's a big.
In China it's available. I think it's mainly available, but it's the
Yeah.
cost. But right now, because
But
rituximab,
very
we're
young,
using the
correct,
biosimilar, is what? Very, very
So it's
inexpensive, I would
interesting.
say.
Maybe there's a lot for us to work on in the CLL group to find out why.
And yeah, and the other thing is maybe I can ask Stephen for his opinion, because as per Burano, we know that for the relapsed refractory setting, the only sort of approved or licensed combinations of venetoclax together with rituximab. Do you think that we should actually use venetoclax together with obinutuzumab in the relapsed refractory setting instead of per Burano regimen?
Well, the dilemma is that there's no trial for that. And so we don't have the data. Therefore, I can't provide you with a scientific answer.
Personally, would you, let's say, outside sort of
look,
clinical...
I've had a couple of patients who've ended up getting obinutuzumab instead of the rituximab because when they've gone along and registrars have phoned them through to our PBS as thinking they were frontline rather than second line. They may have had very short period of chlorambucil a long period of time ago, for example. But so apart from that, we can't provide a scientific answer except for the CLL13 study, which, as you say, very clearly demonstrates a difference with abina that's superior to rituximab when combined with venetoclax.
Other questions? So for relapse setting, just go down a bit without any evidence of using VO. Comparing between VR and V alone in relapse setting, which one you prefer? From Murano, you have to use venetoclax plus rituximab without head-to-head comparison whether any addition benefits of R, and there's approved venetoclax single agents for relapse setting. Would you prefer between VR and V alone?
So VR or VR?
VR or V alone?
Okay.
Okay. Monotherapy.
Yeah, so look, I mean, I think if you've got access to rituximab, the Murano study that was using VR, so I would usually use that according to the Murano protocol.
Now, Stephen, you talk about MRD-driven approach to manage patients with CLL. So with the two, well, right now we have two ways of looking at MRD for CLL. One is by multicolor flow, and the other is typically by NGS. So which one do you think at the end of the day will win the battle? Well, most people will use one or the other.
Yeah, so look, I think that, at least to me, is a fairly clear answer because all of the studies have been using MRD by flow, using the, your name, the ERIC technique, i.e. the European Research Initiative on CLL, that was the trial that was conducted by Andy Royston. And in fact, it's Andy that, as you know, runs the flow cytometry for all of the FLAIR study out of his lab in Leeds. So I think the fact that that's what's effectively the trial proven methodology with the FLAIR study, and that virtually every laboratory of any significant size has got a good flow cytometry lab and perfectly capable of running it. I suspect that will be an easier than NGS.
Because right now in Hong Kong, we do have both technologies available, although we are not doing routinely MRD, some sort of clinical trials that we may use to look at MRD for CLL. But right now, I don't think it's still the right time to use this MRD approach unless we have accumulated more data, how to, utilize better the MRD results to guide our treatment. So what about in Thailand? What's the current situation for in MRD for CLL?
So we have MRD available in only some institutes and mainly not in clinical practice. We don't use MRD for driving any treatment. So it's just kind of like okay, so just the test and in the clinical trial or something that we don't use that for practice. Yeah. And we don't have like the only some facility in Bangkok, not entire the countries having the MRD. And we have both, we can do both from by flow and NGS.
I think flow is probably more commonly used for CLL, perhaps because we use also float for measuring ALL, MRD as well. So that's why I think most laboratories, at least in this region, use flow cytometry analysis for CLL, MRD. What about in Taiwan? Any
I think the
preference?
key question is that actually we don't have a quite effective therapy in Taiwan widely available for everyone. So if you have no effective treatment, then you don't need to measure because most of the patient actually has residual disease, not minimal residual disease. But I think flow cytometry measurement can be available in most of the Taiwan center because it is as easy as that in ALL and AML. And maybe in the future, if one day we can take a chance to cure CLL, then we maybe probably need NGS measurement because then I think there will be even deeper measurement for than the flow cytometry analysis.
Yeah, you're quite right because if you use single agent, in particular single agent BTK inhibitor continuously, there's no point of monitoring MRD at all. Yeah. Yes. Yes. What about in China? Do you do MRD measurement for CLL?
Usually in real practice, we do not recommend the MRD driving treatment in CLL, but we recommend it for use MRD guiding study in the fixed duration study. So such as right now I have launched the first line therapy with Zamrutinib and Zamrutinib with Solantoclax, a new BCL2 inhibitor. In the first line, we designed the MRD driving study.
Right.
That's for.
Okay.
Well, we can use both NGS and flow.
Yeah. What about in Malaysia, Professor B?
I think we are quite similar to Taiwan because the treatment.
Yeah, certainly agree. Now, the other questions that I have in mind is, forget about triplet. Let's talk about doublet, venetoclax based. Venetoclax plus an anti-CD20 antibodies or venetoclax plus a proton tyrosine kinase inhibitor. Which one do you think is a better regimen, doublet regimen for patients with CLL? Perhaps Stephen.
Well, that study's in progress, as you know. Well, I mean, not ibrutinib, but Acala, that's going to be partly addressed at ASH this year with the Amplify study. I think we just await the data.
I mean, right now, if you have a patient in front of you.
Okay, so if you've got that. And as we've seen from the 6-year follow-up data, you get pretty good results. But if we end up in a situation where the funding and regulation allows us to use MRD as a baseline, as a structure for therapy, then it's going to end up with superior outcomes, as we saw with the FLAIR study. And it's difficult to argue with a 97.2% 3-year PFS rate.
And you avoid the infusion reaction associated with the anti-CD20 antibodies. And the other good thing is about convenience or oral medication. You don't have to go back to the hospital for infusion. But the thing is, what about, I mean, those with cardiac problems that you won't want to, even, I mean, it's a fixed duration, do you want to completely avoid BTK inhibitor completely in such patients?
Not necessarily.
Underlying atrial
as you know,
fibrillation, heart failure.
If you've already had AF and got it under control, those patients are treatable. Really a tough don't treat. So that went into florid cardiac failure. So I'm not going to use it in her again. But really, we've had ibrutinib for a decade. Really, if you participated in Resonate, a decade and a bit. And I think most of us, everyone in this room is going to have their level of contentment with cardiac complications and utilisation of ibrutinib. It depends a little bit on your access to a cardiologist, which in some institutions can be a challenge itself. And so, look, I think if you're in a situation where you've got minimal or no cardiac disease or established cardiac disease that's well controlled, use it. So, pretty small number that you can't utilise.
Right. Now, another question. You also mentioned about the Alpine study, comparing, I mean, in the relapsed refractory setting, zanubrutinib and ibrutinib. And there is a superior efficacious advantage with zanubrutinib. How would you like to look at this data? Do you think that is genuine or?
So, as you're rightly pointing out, the Alpine study, which Jennifer has updated just recently and is shortly to be published in Blood, actually has an accompanying commentary with it. And so in that commentary, you'll note that there's a better outcome with zanubrutinib documented in the trial. If you then go back and look at the looking at the supplementary data, you'll see that Australia and New Zealand actually, their patients actually were slightly in favour of ibrutinib. It's slightly in favour of zanubrutinib. Asia and in particular North America, it was strikingly in favour of zanubrutinib. So that's one consideration. Consideration number two is the refractoriness profile. As you know, if you use ibrutinib, the most common mutation is cysteine 481, and you can still then use PERTO or non-covalent BTK inhibitors. But if you get L528, then that gives you the kinase dead mutation, and no BTK inhibitor works. And although in the study, Jennifer's actually looked at, and there's actually a low, not published in that paper, by the way, there's actually quite a low incidence. Nevertheless, anecdotally, I've seen L528. Look at a reference lab, seeing an increasing number, and so you're effectively losing two classes of drug. The other consideration is, I won't deal with all of them, you'll be able to read it shortly, but the other issue is that there's let me use the word discussion in the CLL community about why the Alpine study had 20 percentage point worse outcome with ibrutinib than the original Resonate study did. That was conducted 10 years ago, at a stage when people were much, much more desperate and heavily pre-treated than they are at the moment. And to be honest, although there's two MIAC, that is matched comparison studies available, they're both referred to in the discussion of the paper and also in the commentary. But I think there's still concern by some in the CLL community that in Alpine, the ibrutinib arm underperformed.
So that's why when we look at paper, don't just read the abstract. Do look at the supplementary data as well. So I think with that, I think we should have discussed enough CLL. So I would like to thank the speakers, our panelists for participating in this session. Thank you very much. Thank you.
Thank you very much. I think we should move on to the next sessions, right? It's going to be an industry and engagement session. I would like to introduce chair and the co-chairs of the sessions, Professor Coyote from Singapore General Hospital and Professor Supon Janjarini from Ramathipati Hospital to the stage.
Okay, we move on to the next session. So this is an industry engagement session. As you know, this was a highlight feature of our consortium. We realized that to improve the outcomes of our patients' access to drugs and education and so forth, we need to partner the industry. So it is an active feature of our when we started up the consortium. The feedback from our first meeting was that the session was too short. We actually gave them like 3 minutes to one to three, half to 2 to 3 minutes for each one, and it was like hardly enough. So the request to lengthen the sessions. So we have done that, and then we're also going to invite the panelists virtually as well as in person up front to sit so that you guys can engage. And we've heard some of the feedback about drug access, why certain drugs are not here, why you can't get venetoclax in Thailand and so forth and so forth. So all this we can actually discuss, right? So on behalf of my co-chair, maybe we can ask the various industry to come out and present, and then we can also take the questions later together. So my pleasure to invite the first presenter, Kope, Medical Director of JPAC MGEM, to come up. And Kope, we are really glad to have you as well as our Taiwanese colleagues, I forgot to say, because they actually survived a massive typhoon, the biggest typhoon to hit Taiwan, and then managed to join us in time. So thanks, Kope.
Yeah, thank you, Professor Gao and Supong. Yeah, this is the valuable opportunity. We can have so many Asia Pacific hematologists here in discussing about the leukemia care. My honor to introduce Engine to the audience. Engine is a biotechnology company that we develop medicine to fight the world's toughest disease. The advantage of Engine is the innovation at every stage of drug development, from the drug discovery to find the drug target, and also the molecular pathway. And also we have development of the drug use our unique protein engineering platform. And also we deliver the drug with the world leader biotechnology manufacture capability. Beyond light, Engine not only push the boundary of biology, we also speak to patient. We find the accelerated pathway to get the drug approval or advance clinical trial. And we also use our biomanufacturing capability to develop biosimilar for more patients can be benefit from biological treatment. These are currently in clinical development, the Engine oncology pipeline. You can find there are some precision medicine that use the monoclonal antibody or small molecule. We also have some immuno-oncology therapy that leverage on the BITE Engine-owned BITE immunotherapy platform, and also the checkpoint that we identified and also developed. Now we focus on the bispecific T-cell engager BiTE immuno-oncology therapy. Yeah, you may know there are already a lot of T-cell engager, bispecific or multi-specific, which already approved or in development in multiple myeloma and also acute lymphoblastic leukemia. These are the concept of BiTE to put the cancer cell and also T cell together, and the T cell will lysis the tumor cell and also expand more T cell to identify the cancer cell. Engine development the BiTE in very early in 1985. In 2004, we have the first bispecific T cell engager, blinatumomab, advanced to the clinical trial. 2017, we have the pipeline extended BiTE in development, and now we already have the drug in the market. So for this BiTE, there are different types of BiTE in engine. From the very early stage, the canonical BiTE, and also we attached the FC portion. We have the pipeline extended BiTE. We also have 2+1 bispecific antibody to enhance the tumor antigen binding, and these triggered the T cell cytokine release. And also we have this kind of dual targeting BiTE currently is under phase 1 study. Let me introduce blinatumomab. I think most of you already familiar with this first generation BiTE, and also know it induced cytokine release syndrome in the first 3 days, and also the sustained exposure can maximize the clinical effect and also T cell migration. It also can reduce the tumor burden very fast, but it's also influenced by target selectivity and also accessibility, especially if we want to use this technology into the solid tumor. And there are also some drug resistance mechanisms to be identified for the target depletion and also compartmental mechanism. So Engine is working on improve this BiTE. We have the half-life extension engineering and also subcutaneous delivery solution. And also we applied this BiTE platform to different solid tumors. And we designed the new drug to reduce the cytokine release syndrome or even neurologic toxicity. And also we are thinking about the different combination treatment strategy or the alternative or sequence treatment strategy to enhance the tumor cell deletion. This is the tarlatamab. It's a DL3 BiTE. We attached the FC portion, so it can be dosing every 2 weeks. So in May this year, it's already approved by FDA to use in the small cell lung cancer. So now the next bispecific T cell engager I would introduce is ANG 509 larutamig. It's step 1 and CD3 2+1 antibody. You can see there are 2 binding sites for the tumor antigen and 1 binding site for the CD3 T cell. So we hope in this drug design, you can see in the low concentration, the binding for this 2+1 T cell engager, there are higher binding to the step 1 cell binding, but the less in this kind of traditional bispecific T cell engager. So in this, we can bind the tumor or identify the tumor at very low concentration and avoid the cytokine release syndrome. So in phase 1 study, we already identified this is quite effective to reduce the cytokine release syndrome or even the neurologic toxicity. But it also have the new toxicity we found is musculoskeletal syndrome. So this year, this compound will advance into phase 3 in prostate cancer. Next one I will introduce. This is the dual targeting BiTE. You can see this FC portion combine two of BiTE. One is anti-mesothelin. The other one is anti-CDH3. What is mesothelin and also CDH3? CDH3. CDH3 is cadherin 3 and also mesothelin. They are both the tight junction and also cell adhesion function. So in the normal cell, you can see if we stain the CDH3, it's only in the basal layer, basal cell layer. The layer are light brown colored in this. And also in the lung mucosa, we can see there are only light stained in the mesothelin. These are the expression in the normal cell, but you can find in the cancer cell, the cell alignment is disrupted, so they can stain and also express CDH3 and the mesothelin very much. So we designed a drug that we hope this drug will not attack the CDH3 express only or mesothelin express only the cell, but attacked this kind of two target expressing tumor cell. You can see in the low concentration this red line, it can attack or have the cytotoxicity in this both target expressing tumor cell. And this is highly rated, 70% to 90% for this co-expression. The last one I will introduce is CCR8 inhibitor monoclonal antibody. It's a checkpoint in the tumor regulatory T cell. We know tumor regulatory T cell, it will depletion the normal cell CD8 cytotoxic lymphocyte and also CD4 lymphocyte. So we design an antibody with alpha-cosylated FC portion that will increase the ADCC effect when this antibody binding the target. You can see if non-depleting anti-CCR8 antibody, there is no tumor shrinkage. But when we have this depleting anti-CCR8 antibody, there are a certain portion of tumor will have response and shrinkage. And we in clinical study, we also try to find which tumor marker CCR8 or tertiary lymphoid structure is relevant or related to the clinical effect. So that's our strategy in precision medicine and immuno-oncology therapy. We hope in the future there are more clinical data for the combination treatment strategy and to deliver for every patient every time. Thank you so much.
Thanks, Kobe. Maybe you can come and sit here. Can we next ask Kenny Lee from BMS? Thank you.
We built a company differently from the very beginning. It's built to do great science and to deliver impactful medicines.
And it's built to maximize quality, speed, and affordability, so we can truly meet the urgent needs in cancer. More than 10,000 people across 5 continents are working relentlessly for patients who are our North Star. We are an oncology powerhouse with more than 1,100 expert scientists and a proven track record of developing medicines that address significant needs in blood cancers and solid tumors. In addition to one of the largest oncology research teams in the world, we have a distinctive entrepreneurial culture and extensive in-house capabilities to reach more people more quickly, wherever they are. The scale and structure of our internal development team allows us to run clinical trials in-house, reducing the cost and improving the speed of drug development by up to 30%. And our internal team and custom technologies ensure quality, In this way, we have built one of the largest and most compelling oncology pipelines in the industry, focused on blood cancers and solid tumors to address 80% of the world's cancers. We also have significant cost advantages in manufacturing, leveraging economies of scale for producing biologics, small molecule, and other innovative modalities. To further expand global access, we continue to invest and build our global teams and facilities, including a flagship U.S. manufacturing and R&D facility at the Princeton West Innovation Campus in New Jersey, which gives us greater scale and broadens our capabilities to develop and deliver medicines with our patients-first focus. All patients deserve access to medicines that can change their lives. We strive to work closely with health systems globally to accelerate patient access to our treatments. We deliver more than medicines. We deliver hope. Built differently. Beijing.
Good afternoon, everyone. My name is Kenny. I'm from Beijing, Malaysia. And since Beijing's establishment in 2010, we have definitely forged our path in transforming patient life through spearheading the new global model in expanding global access to medicine. And Beijing has a world-class oncology R&D engine in both solid and liquid tumors to serve 80% of the world's cancers by incidence. And in hematology, we have cemented our leadership with zanubrutinib with the broadest label globally. And beyond that, we aim to expand our footprint in other indications as well as in all lines of therapy. You can see here, this is our global clinical development pipeline. The red dots are all our hematology assets, and you can see it is across all phases. Feel free to drop by our booth if you'd like to know more about them. And lastly, I'm very proud to say that since the past 14 years, we have treated more than 1.3 million patients, and this is really our North Star in everything that we do in Beijing. Thank you.
Thank you, Kenny. Can you please sit? Sorry, I call you BMS. So me now we have Aisha from BMS.
So a very good afternoon. Professor, you've been thinking about BMS. Just jokes. So before I begin,
Is your coffee?
You need our coffee. Before I begin, probably I'd just like to introduce myself. I'm the Senior Scientific Advisor for Singapore, Malaysia, and I'm very honored to be standing here in this room to represent BMS Hematology APAC team. Today I'll be sharing the exciting advancement and unwavering commitment of Bristol Myers in the field of hematology. So BMS is a global top 10 biopharmaceutical company dedicated to discovering, developing, and delivering innovative medicines with over 100 years of history. And I think if you've been in hematology or even medicine long enough, you will probably know that hydroxyurea is one of our anti-cancer medicines since 1967, and is still very much used in hematology space, including as other cancer treatments. And since 2023, we are the top 10 biopharmaceutical company. And apart from hematology, we are also expanding in immunology, cardiovascular, and recently with neurology. And I'll be speaking for Singapore, Malaysia, and Thailand because this is where the cluster that I am from. And currently, our focus are these three products. We have first, fedratinib, which is indicated in first-line and second-line myelofibrosis in intermediate risk 2 and high-risk MDS, and it's been approved in Singapore, Malaysia, and Thailand. And then we will have oral azacitidine, and this is also why the reason that we are here. Oral azacitidine is a treatment for maintenance, post-intensive chemotherapy, and we have also been approved in 3 countries. And currently, our main focus is luspatercept. This is a novel agent targeting the erythroid maturation agent, erythroid maturation, agent, currently indicated for TDT thalassemia, low risk MDS, and we are looking into expanding in myelofibrosis, alpha thalassemia, and also in pediatric indication. And our commitment to hematology extends beyond to what we have currently. We are also having, I think you will know, ide-cel in multiple myeloma. Currently, we also developing GPRC5D CAR T, and we're also exploring the use of dual CAR T therapy in multiple myeloma. In the near future, there will be iberdomide and mezigdomide classified as CELMoDs targeting protein degradation therapy. And for DLBCL, we have lysocell and golcadomide, which is targeting protein degradation as well. And luspatercept, yes, as I've mentioned earlier. And finally, just to show you how we are committed in advancing science in hematology, and especially focusing for this region, including China. You can see we are, apart from the BELIEVE trial with luspatercept, which is currently still ongoing for a long-term follow-up, we have opened new clinical trial sites for golcadomide in Thailand and Malaysia. And we are very happy to share that we also opened a new clinical trial site for CAR-T GPRC5D in Singapore. And I hope that with all this new clinical trial footprints and approval of hematology products in Southeast Asia, we can expand our focus in the region, and we are hopefully looking into expanding patient access in Vietnam, Indonesia, and Philippines. And finally, we want to make our products more accessible to the patients in the region. So thank you very much.
Thank you, Aisha. Next, we have a new company. Very excited to introduce you to Wing Tong from Cayenne. It's a new homegrown sort of biotech company to introduce their latest technology. So we're happy to have them as our first sponsors. So Wing Tong, yeah.
Hi, good afternoon, everyone. Thanks, Prof. Go and introductions. So I think I will switch the topic a little bit. So I think previously, I think 3 of my colleagues talk about drugs, like which medicine, which is the novel medicine. So I will talk about which drug to be used. So as Prof. Go had mentioned, Cayenne Technology, we are a Singapore homegrown diagnostic lab. We actually spin out from NUS. So our technology that we'll be talking about actually developed from UCLA and from NUS for the past decades. Oops, sorry. Yeah, but we already have spin out to become a private company since 2 years ago. Yep. So we've been operationally, commercially for 2 years. And currently we have a presence, commercial presence in Singapore, Malaysia, Indonesia, and Thailand. Also, we have some distributor in Europe and Middle East as well. Our next focus really is really to move on US and also to look at some other market in the Asia Pacific regions. So the technology that we're talking about basically is something that I will say something rather that a lot of people have been aware of it, but we try to do a new twist of it. So it's a functional precision medicine. So what we are do for the cancerous patients, the patient actually who have a cancer, we'll actually isolate the live cancer cells from their body. Then in our lab, we'll culture them with a panel of drugs. And from there, we look at which drug actually is the most sensitive and which drug the patient might already develop resistance for them. And this is particular in the relapse and refractory settings where the patient might actually lack of options, or maybe there are multiple options under the guideline, but there's nowhere for us to prioritize which one to be used. Yep. So what's the new thing we'll talk about? So the platform that we're talking about, the ex vivo drug sensitivity testing, really have been used by years, I will say, in the multiple settings, especially in the research, in the drug development. I think in the real clinical setting, the what is always a limitation is the time. We actually need to turn around the result very quickly. And secondly, is a limitation of tissue. So with that, what we have really developed is a proprietary small data AI system that actually could help us to isolate the data. So from what we have over here, we actually isolate the the cancer specimens. We actually do a drug testing in the lab. Then we actually pump the data into a small data AI, which actually help us to predict not only a single drug sensitivity, we actually look at the combinatory, so we can actually predict the outcome in so 2 drug combinations, 3 drug combinations. Then we actually rank them accordingly. So we return the result in a report in there in terms of the top ranked single drug, 2 drug combination, and 3 drug combinations. And this is particularly useful, as I mentioned, in the relapse and refractory settings, leukemia or lymphoma, where there might be multiple options to be prioritized, or when there's a limited option and you want to look for some of the off-target or actually repurpose some of the drugs. Based on our clinical collaboration in Singapore with, especially for institute like NCC and NUH, we actually have done some of clinical validation, especially in non-Hodgkin lymphoma and also AML. And actually, we have achieved a consistent accuracy of 80%. Yep. So this is something that to be due to publish within this year. In non-Hodgkin lymphoma, we actually can see there is a clinical benefit where the patient, wherever they're actually receiving our optimized guided treatments, we can consistently show that the patient actually responding better comparing to the patient in the relapse cohort. And actually, we show some benefit in terms of the overall survival and also PFS as well. Yep. So I will say that as our company, as I mentioned, it's really rather new in the clinical diagnostics scene. We are very excited, but actually we just get started as well. So I think we are really looking forward to work with all of you, and we will still be around until tomorrow. So let's say you have any interest, you want to discussion, please drop by our booth. Thank you.
Thanks a lot, Ho Bing Tong. I hand over to my co-chair for our virtual sessions.
Thank you very much. Now we have a presentation as the virtual presentation from 4 industrial company. First is let me ask Michael Akenhead, who is the Regional Medical Affairs Director, Leukemia and Lymphoma from J&J, to present video, please.
Excellent. So good afternoon, everyone. I hope you can hear me okay. My name is Dr. Michael Akenhead, and I'm J&J's Regional Medical Director for Lymphoma and Leukemia. On behalf of my Asia Pacific colleagues, I would like to thank the APLC Summit Organising Committee for the opportunity to present our portfolio in B-cell and myeloid malignancies. So at J&J Oncology, we have a bold vision. It's the elimination of cancer. Now, our vision is underpinned by over 30 years of innovation in oncology, which includes first-in-class therapies such as ibrutinib and daratumumab that have extended lives and established new standards of care. Now, we're achieving this vision by delivering transformational regimens to achieve cure or prevent disease progression. Now, the growing importance of Asia-Pacific markets in J&J's oncology development programs reflects our commitment to patient diversity and inclusion in our clinical trials. So shown on the slide is a high-level summary of J&J's hematology portfolio and our focus areas of B-cell, myeloid, and myeloma. Just looking at the top of our B-cell pipeline, you can see we have an array of targeted therapies, including bispecific and trispecific antibodies, CAR T-cell therapies, and small molecule inhibitors. Now, our myeloid portfolio shown just below includes bleximenib, which is a promising oral menin KMT2A inhibitor, which is in development for AML. We also have J&J 4996, which is a first-in-class bispecific antibody for MPN. And finally, in the myeloid pipeline, we also have a novel neoantigen vaccine, which is targeted against mutated CALR and JAK2 proteins. So let's start with ibrutinib. So ibrutinib plus venetoclax is an all-oral, chemo-free fixed-duration therapy that combines 2 synergistic mechanisms of action to extend survival for treatment-naive CLL patients. As Prof. Mulligan highlighted in the previous presentation, longer-term follow-up of the GLOW study shows a sustained survival advantage, with 85% of patients alive and progression-free at 5 years. Now, I+V, as shown on the right, also provides durable treatment-free interval, with approximately 9 out of 10 patients free from subsequent therapy at the 5-year time point. And importantly, the regimen has demonstrated efficacy across all patient subgroups, including high-risk patients, and is well tolerated with no new or cumulative toxicities over 5 years of follow-up. So beyond ibrutinib, we're committed to developing first-in-class therapies for patients with B-cell malignancies. This includes 2 next-generation CD20-directed autologous CAR-T therapies that have demonstrated promising overall and complete response rates in phase 1 studies. We also have several investigational small molecules targeting the B-cell receptor, including a second-generation MALT1 inhibitor that has potential to overcome acquired resistance to BTK inhibitors. And finally, we're also developing an array of novel T-cell redirectors against different B-cell targets. This includes a tri-specific antibody and also a co-stimulatory T-cell engager, both of which I'll cover on subsequent slides. So let's start with the CAR-T therapies. So J&J-9530 is a next-generation CD20-directed autologous CAR-T therapy. It is showing promising initial efficacy in a Chinese phase 1 study, producing durable responses in heavily pretreated DLBCL patients who had all received prior CD19 CAR-T therapies. Now, this CAR-T is in an ongoing international phase 1b study in adult patients with relapsed or refractory NHL. Now, J&J-4496 is a novel second-generation CAR-T therapy that targets both CD19 and CD20. This therapy has shown high response rates in a phase 1 study in China, which also included patients with aggressive lymphoma. The BiCAR is in an ongoing phase 1 international study in adult patients with relapsed and refractory NHL. So if we just turn to our portfolio of T-cell redirecting bispecific and trispecifics, we have a portfolio of bi- and trispecific antibodies that provides opportunity for combination approaches with the aim of improving outcomes for lymphoma patients. Shown on the left of the slide is our trispecific antibody that binds to CD20, 79B, and CD3. The trispecific is in an ongoing phase 1b dose ascending study which is aiming to determine recommended phase 2 dose and optimal dosing schedule with expected data in the first half of next year. Now, shown in the center is our bispecific co-stim antibody that is being developed for use in combination with T-cell engager therapies. The co-stim antibody is in an ongoing phase 1 combination study with the trispecific that should deliver initial data in 2025. Now, if we just look at the myeloid portfolio, now patients with relapsed or refractory AML and KMT2A or NPM1 mutations have poor outcomes with median overall survival of around 6 months. Bleximenib is an oral, potent, and selective inhibitor of the menin-KMT2A interaction. It's currently being evaluated in phase 1 studies as monotherapy in relapsed or refractory AML, and is also as combination therapy in patients with newly diagnosed and relapsed AML. Now, single-agent activity of bleximenib was reported in a phase 1 study in relapsed AML patients and demonstrated encouraging initial efficacy. As shown on the slide, overall response rates range from 40 to 50%, with complete responses above 25%. Now, bleximenib to date has demonstrated an acceptable safety and tolerability profile with very low rates of differentiation syndrome and QT interval prolongation. And finally, on bleximenib, phase 1 data was presented at EHA recently by Professor Andrew Wei that demonstrated the ability to combine bleximenib and venetoclax plus azacitidine in relapsed AML with patients with KMT2A or NPM1 alterations. So as I mentioned at the start of the presentation, J&J has a broad and expanding footprint of hematology clinical trials across Asia Pacific. This slide provides a snapshot of ongoing or recently completed studies for our B-cell and myeloid assets. Now, we will continue to work collaboratively with local investigators and sites to advance our innovative therapies and to ultimately improve outcomes for Asia Pacific patients with lymphoma and leukemia. So many thanks for your attention.
Thank you very much. Next, Jamie Ann, who is therapeutic area lead hematology for international markets, will present for Astellas. So Jamie, please.
Good afternoon. I'm not sure if my slide is visible in the room. Are we?
We can hear you really well.
Okay, great. Thank you very much. Good afternoon. I would like to thank the APLC for this opportunity to present the Astellas Clinical Development Program. I'm Jamie An. I'm the Therapeutic Area Lead for Oncology and International Markets in Greater China. Astellas is actively advancing its early-stage oncology pipeline, focusing on innovative therapies for various cancers. Key developments currently include immuno-oncology initiatives with a focus on DGK-zeta inhibitors, bispecific antibodies targeting Claudin 18.2 and TSPAN8. Astellas has also entered some strategic collaboration with LP Science to develop SIRP alpha targeting therapies aiming to enhance macrophage-mediated anti-tumor responses. Another key area that's a focus is in targeted protein degradation, a strategy aimed at eliminating disease-causing proteins that are challenging to target with conventional drugs. So these efforts really underscore Astellas' commitment to developing targeted therapies and expanding treatment options for patients with challenging cancers. On market and in late development, Astellas focuses on prostate, urothelial, bladder, and GI cancer. And as we know, the development efforts are ongoing also for gilteritinib in acute myeloid leukemia. While the approved indications for gilteritinib is in the relapsed refractory AML setting, studies are ongoing in the newly diagnosed setting, mainly focusing on the sequence and combination regimens in both high-intensive chemo eligible and ineligible patients. Also, there are currently 2 studies ongoing in the pediatric setting. Astellas' vision is to be on the forefront of healthcare change to turn innovative science into value for patients. And our investigator-sponsored research is aimed at advancing medical and scientific knowledge at Astellas marketed products such as gilteritinib and/or associated disease areas. Our areas of interest and areas of non-interest for gilteritinib are listed here for your consideration and also posted on the Astellas ISR submission website. So thank you again for this opportunity to share the Astellas oncology pipeline, and I wish you a successful APLC meeting. Thank you very much.
Thank you very much. The next virtual presenters from AstraZeneca, Ayman Elsayes, who is the International Medical Director, Hematology, Gastrourinary, and Lung Cancers, will present for AstraZeneca. So,
dear guests, welcome to our session on the AstraZeneca hematology pipeline. Today, we gather to explore the exciting developments and future trajectory of our hematology research and developmental efforts. As we navigate through our current pipeline, we will highlight not only the groundbreaking therapies that are on the horizon, but also the strategic initiatives that drive our commitment to excellence in patient care. My name is Ayman Elsayes. I'm the International Medical Director in AstraZeneca. I'm excited to share the remarkable progress our team has made over the past years. Our unwavering commitment have resulted in the successful approval and launch of acalabrutinib second-generation BTKI in both CLL and MCL. Additionally, our R&D team are currently advancing through 4 phase 3 trials targeting multiple hematological malignancy. Our pipeline is robust with 30 innovative R&D projects currently underway, which include 9 clinical assets showcasing our collaborative approach to advance hematological therapies. At present, we have 26 active clinical trials across 9 diseases, which speaks volume about our dedication to tackle some of the most challenging hematological conditions. What truly set our team apart is our end-to-end approach in delivering the AZ hematology portfolio. Let me share our hematology strategy, which is focusing on 2 key objectives: building combination regimen to address tumor heterogeneity and intervene throughout the cancer quantum to drive towards cure. And We are pleased to share with you 9 assets in hematological treatments, centered around 5 key pillars: cell therapy, immune engagers, ADCs, tumor drivers, and epigenetics. These innovative strategies aim to improve outcome for patients with multiple myeloma, non-Hodgkin lymphoma, and CLL, ALL, and follicular lymphoma. I'll just focus on 2 assets, which is the AZD0120, and this is an advanced dual targeting CAR T cell therapy focusing on both BCMA and CD19, crucial for the treatment of the multiple myeloma. It featured a shortened manufacture time, which increased the capacity and reduced the patient waiting time. Additionally, it requires a lower cell dose than the traditional CAR T therapy, minimizing severe side effects and enhancing tolerability. In clinical trials, the AZD0120 has shown impressive results, particularly in newly diagnosed high-risk multiple myeloma patients, achieving a negative MRD in many patients 1 month post-treatment, suggesting deeper and more durable responses. For the immune engagers, we have 2 bispecifics. One of them is the AZD0486, which I will share it now. It's a bispecific designed for multiple diseases: follicular lymphoma, DLBCL, ALL, and CLL, also targeting both CD19 and CD3. And as a fully human monovalent antibody, its benefit from improved safety profile and reduced immunogenicity. Its unique CD3 binds with a low affinity to minimize excessive cytokine release, while the CD19 binds to the tumor cell. It also have a long half-life, enhancing the patient compliance. Clinical data indicate a durable response in heavily pretreated or refractory follicular lymphoma, ALL, and DLBCL patients. In summary, our strategic focus and innovative assets position us to make significant strides in hematology. Together, we are not only advancing science, but also paving the way for better patient outcome. Thanks for your attention and looking forward for our discussion.
Thank you very much. I'm glad that Ayman will be with us in the Q&A session. You can say hello now. Okay. So next, we have Gary Gu, who is Regional Medical Director, Oncology Asia Pacific Middle from Novartis, to present the products.
Hello, everyone. I hope I'm audible and you can see my slides. Okay. So
yes, I can see it very well.
Thank you, Chairman. Thank you, APLC. First of all, on behalf of Novartis, I would like to thank APLC for this opportunity for me to representing Novartis, presenting our collaboration and pipeline to you. It's a last but not the least presentation for this session. But it's very important for Novartis to be here as well. So I'm going to introduce myself. I'm Gary Koo. I'm the Regional Medical Director for Oncology, APMA. APMA in Novartis stands for Asia Pacific, Middle East, and Africa. It's our region's name. Okay. I would like to present our purpose, Novartis' purpose and vision and value and behavior. Our purpose is reimagine medicine to improve and extend a patient's life. We have a vision to become the most valuable and trusted medicine company in the world. Our value and behavior underpin our culture. That we encourage our Novartis employee, to be inspired, curious, on board, and have integrity. So Novartis has 5 pillars in our whole pipeline. It's a very high-level view that we have cardiovascular, immunology, neuroscience, solid tumor, and the hematology. So hematology is one of the 5 important pillars of our development. We have our platforms that most of the hematologist doctors must understand that we have chemistry, we have biotherapeutics, but now we have some novel platforms, including the RNA platform, which is targeting mostly on the cardiovascular side. We have radioligand. Currently, radioligand is targeting on solid tumor, but we also have a gene therapy and cell therapy platforms, like we have the CAR T in the market for our hematology patients. So this is also our high-level pipeline overview. If you see into the hematology, our disease area, focus area will be non-Hodgkin lymphoma, lymphoid, non-malignant hematology, including ITP here, and also acute myeloid, the myeloid MDS here. For our pipeline, we have iptacopan, which is our complement pathway inhibitor targeting PNH and AHUS in our development. We have ianalumab, which is VAY736. This is a BAFF antibody. It's targeting ITP and YHA in our pipeline. We also have YTB323. This is our second generation. It's CAR T. This generation of CAR T, we call it T-Charger. We have to make a shorter turnaround on the manufacturing so we can benefit the patient more. We also have a very broad interest from phase 1 to phase 3. On the phase 3, we already have Semblix, our ABL001, which is targeting BCR-ABL. Of course, you know that we'll be targeting CML in the development, and here is the iptacopan I mentioned. There's another asset in the CAR T, BCMA targeted CAR T called PHE885. We have a tri-specific antibody. It's a T-cell engager with CD19, CD3, CD2. It's called PIT. We have a DFB890. It's a NLRP3 inhibitor, which is targeting the inflammasome pathway of the myeloid disease. This is generally our hematology pipeline. And thank you for your attention.
Thank you very much. Actually, for the FB, there is no representative from FB, so we now would like to start the Q&A sessions. So I turn the mic to Dr. Go.
So you guys can either ask questions raising your hand, or if you're a bit shy, you can actually text your Slido and text your questions in, and we will take it from here. So it's actually medical, so it's open to all for anything, all comers, pipelines, registered, unregistered indications, difficult questions, embarrassing questions. Feel free to ask. Okay, so no holds barred. Maybe we can start with Kenny. Remember, we heard that Evie is not here, and we heard that there's quite a big need for BCL2 inhibitor in Asia Pac. And of course, we know that you guys have your own Beijing BCL2 inhibitor. How far is it coming along? I know that you have some trials with some of the companies for AML and in combination, and also in CLL lympho that. So how far along can we expect it to come along? Will you be
So the sonrotoclax, our BCL2 inhibitor, the phase 3 studies has just been initiated. So it will be about 3 to 4 years before it will be commercially available. But do look out for the compassionate use program that probably will come in 2026-27.
Right, and then the CL group or the other groups, will there be IITs? How do we get to IITs? If, let's say, you know, in countries that don't have venetoclax, what is your IIT route? Do we go online? Do we reach out to the regional person or the local person?
For hematology, I'm sure most of you do know our regional hematology lead, Pooja. And now we have presence already in Thailand and Malaysia. So we have medical personnel in these two countries. And so feel free to reach out to your local respective team, Beijing team, or else you can just drop by at the booth. So for Beijing, as you have seen from the video, we have our in-house clinical operations team. So we are very active in doing industry-sponsored researches as well as investigator-initiated trials. Yeah. So we're definitely open to opportunities to collaborate with you all.
But do you want to ask any of the panel, virtual or in person otherwise? Or in fact, you guys, Mike, Hai, and all that can also ask audience questions also, both ways, two-way dialogue.
I have one question and also the same question from our audience online. What can we do to attract more clinical trials into these regions? The Asian population is still minimally represented in most hematology trials. So I think this question is open to anyone who would like to.
Maybe we take all the questions because we don't have time to go around to everybody. Second question is, what are the panelists believe are the current biggest impediments to drug development? That's very broad. So we're going to put all of you on the spot. Say clinical trials, more clinical trials in Asia Pac. That means commercial trials, and then IITs also we are open. IT is a bit difficult because we have a clinical trial group, but it's a bit difficult to do IITs. But if you want IITs, if any of our working group want IITs, I mentioned last year, we will have to do it in collaboration with either a trial group like the Australian ALG or something, and then it has to be like company sponsored. Then the last question was CAR T. Okay, we'll leave CAR T out. Okay, so I don't know who wants to go first. Amgen, you want to to say what are the impediments, and then are there more trials on board?
Yeah. Bring clinical trial into Asia Pacific areas. Currently, for Australia, Japan, South Korea, Taiwan, most of the trial, especially the phase 1, phase 2 early clinical trial was deployed to these countries. And these 2 years, we also involve Singapore, Hong Kong, and also Malaysia and but currently, most of the trial are focused on the general medicine, cardiovascular or metabolic clinical trial. But I think in the future we can bring more cancer trial into this region. If physicians are interested to some of the compound to initiate the investigator sponsored study, the engine is open for this. We have the open web. You can submit your idea. It's called enginiss.com. So you just www.enginiss.com. Then you can access this resource, submit
or contact your local MGen rep. Maybe we move to one virtual. Mike. Hello, Mike. It's too bad you can't join us. And obviously, your menin inhibitor has attracted a lot of attraction. And then I know that some of your regional team have been asking around for survey on your menin inhibitor and some of the other assets. So you want to comment on what are the impediments as well as your clinical trials in the region? Are there plans to bring in to the Asia Pacific, and will you be keen to work with APLC and so forth?
Yeah, so I was going to say that probably one of the key impediments to bringing trials here is actually convincing, particularly our large farmers, that they have to move beyond being US or European centric. So I would say over the last 4 to 5 years in particular, J&J has made a big push to bring clinical trials to the Asia Pacific region, in particular, early phase clinical studies, first in human studies. And I think one of the ways of overcoming the impediments to getting the trials here is actually bringing our US and European colleagues out so that they can see how good the sites, investigators, and infrastructure is to run trials in this region. So you probably remember that last slide I showed in my presentation that showed quite an array of trials that are running across the region. Many of those studies are in fact first in human phase 1 studies, and at least 3 of them enrolled their first patients here in Asia Pacific. I think if we're talking specifically about Lexamin, our AML therapy, it is ongoing at a number of sites here across Asia Pacific. There are plans when we move forward with the agent, which is looking very promising, to expand our enrollment across the Asia Pacific region. I'm not sure if Jasmine, my colleague who's in the audience, wants to make an additional comment about that, because
Jasmine
she
is in the audience, but you put her on the spot. Jasmine, you want to say anything?
Hi everyone, Jasmine over here. I'm actually part of the J&J Asia Pacific commercial team. So maybe just echoing Mike, we are definitely committed to partnering with all of you in the region. And like what Mike also mentioned, Leximanid is developing quite well, progressing quite well. So in the coming I would say, months and years, that there'll be more information on that. And looking forward to work with you guys to see how we can actually continued collaboration.
Okay, thanks, Jasmine. Maybe BMS actually has been quite good. I think we just had a very nice successor meeting in Japan for their CELMOD and a lot of the countries. I see a lot of the people here. So BMS is actually actively reaching out to us for trials, barriers to maybe getting the region and so forth. So Aisha, you want to comment?
This works. Yeah, I think I would like to echo what Mike shared. I think it's definitely due to unfamiliarity. Hello. Yeah, just because I think most of the companies are Europe and US centric. I think organizations like APLC, AMN, such regional networks will bring, I think, more interest to this region. And of course, I think working with local partners like Singapore, like me, and then our team in Malaysia and Thailand, we need to always elevate and always put our hands up when there are meetings. And in fact, I think I have probably reached out to most of you. I think we've done at least 6, 7 site feasibilities to get one successor to clinical trials. So the effort continues from both sides, persistence definitely, and then again, I think this such of network really helps to show that all of us are actually working together in this advancing science. Yep.
Thanks, Aisha. So Gary, Novartis, I think my experience with Novartis goes a long way. I mean, 10, 15 years ago, we started the first phase 1 and then first in human studies out of Singapore, and we did quite a fair bit of all your trials, successful and successful. It's very, very long story. So Novartis is active and engaging Asia Pac, especially for oncology, hematology. So we hope you guys can, of course, with Semblix, our sites were involved in your developmental studies, and hopefully you guys can be more active in Asia Pac in terms of joining us for your sponsorship, joining us, in a more finite way, and we hope to see you in person. Anything to comment, Gary? I will hope to see you more in person when I meet you.
Yes, thank you, Professor Goh. That's looking forward to meet you in person. And I would like to comment on the clinical trials. Novartis has like a separate unit doing the clinical trials. So for me, I'm a little bit like an outsider observing that they are now looking into the startup time, very in detail, that they want to have a shorter startup time. And we are introducing some AI, so the data infrastructure for every site to be ready. To be involved in all the global clinical trials are very important. And I think for our region, I would like to remind every investigator here that the networking is very important. I think all the colleagues here will agree on this one, that the networking with the US, European colleagues are very important.
Yeah, I guess we have to depend on you guys to network and then go up to the global. So if you're very active, you need to then work through your local people to go to US to pitch your IITs and so forth. And we've done that with imatinib and nilotinib and all the way for that, Rick and all that. For Kenny, I think you guys are also quite active. We've received some of your feasibility for your new BCL2 inhibitors combinations for various things. Are there any countries that you want to talk to or that reach out to a little bit more for Beijing?
So definitely in the Southeast Asia or even APAC region, we are definitely trying to bring more studies, especially in the hematology or solid tumor. If you're aware, we do have already at least 2 first-in-human in Malaysia and in other Southeast Asia countries. So personally, it's very hard to pinpoint what exactly is the challenge in Southeast Asia. Maybe it's the Asian pool, but we do have countries like Indonesia. We have a lot of patients. So definitely there is
So that's where we
potential.
can help. So we have actually a clinical trial group, but we don't activate it actively, and we have identified sites in Asia Pac that are capable of doing trials with reputation and so forth. So if you want to reach out to do with us, then you reach out to us. We can give you, let's say you want in Malaysia, we can give you a few places. You want in Thailand, we can give you places and so forth. So then that's where you can collaborate with us. So looking for sites, not a problem. Book with us, all right? So trying to get a lot of business for everybody, I tell you. So Ayman, welcome. So Ayman is new, and we've met before. And Ayman, AstraZeneca has been quite busy shopping around for lots of assets. That China assets made news in the recent EHA with their very fantastic 100% response rate for their so very exciting. They bought a lot of stuff, and I think I'm going to be quite busy looking for collaborations. Correct, Ayman?
Yeah, of course. Thank you very much for the invitation, and I'm very happy to see you, Professor Go. So, as you mentioned, I think AstraZeneca was doing the shopping mainly for the oncology for the past years, and we're focusing on the calquence, just acalabrutinib in the hematology. But in the past, couple of years, we started to widen and diverse our portfolio. And as I show, we have almost 9 molecules, 9 assets that we are working in. One of them, the one that you have mentioned, the AZD0120, which is the second generation CAR T, which is a bispecific CAR T. And it's very interesting that we're talking about clinical trials because we have just talked to the global team and we are trying to include around 5 countries from the international region, 3 of them coming from Asia countries. So we are trying our best, as all the other companies and our colleagues, to include the patients from the Asia Pacific to represent the Asia Pacific. Some challenges that we are still facing, maybe the availability of the patients, maybe the experience of the sites, but I think all of us are very eager to include the Asia Pacific patients in order to reflect the results in our clinical trials and make sure that they're going to use our molecule. And looking forward to include as much as we can of the new site, and of course be reaching out to you, Professor Go, and the society in order to make sure that we are having the ready sites in order to be included.
Okay, thanks a lot. So Jamie, we're sorry you can't come. We're sorry that you don't even have a booth here here at Stellus. And Mark Levis mentioned that he's going to talk to your Brazilian boss to actually support Asia Pac more when he meets you in a few weeks' time. So we hope we can get more active participation from Astellas. I know you guys have done a lot of trials already with Asia Pac. You're involved in your trials already. Yeah.
So Dr. Go, thanks for your comment, and apologies that we had lack of a presence this year. But from Astellas side, for most of our registrational study and phase 3 studies, Asia is recognized as an important hub and has been actually included in our key studies. So I think being a Japanese company, the quality of the clinical trial delivery is recognized amongst these Asian countries. But what's really important is precedent contribution in the study recruitment. And also in Astellas, at least, there's very close collaboration between global development and medical affairs in really assessing the feasibility of the sites that we want to engage. And I think that's when the conversation between local MA and the institution becomes very critical to actually assess accurately the projected enrollment. And I think once that track record is there, I've seen that the company is much more willing for future early asset trials to invest in Asian countries. So I wanted to leave that comment that I think the commitment and interest to expand further in clinical trial collaboration and investigator-sponsored study is definitely there.
Thank you very much. Now, I think we have to come to the last question to Chiang Technologies. What features are you using for the Optim AI predictive models, and would that project to the dose and schedule for drug delivery?
Yeah, so I think we have from a very general discussion to a very specific questions. So I think just now what I didn't mention is that our platform is actually more of a predictive model for sensitivity and resistance of a panel of drugs. What we couldn't really determine from our test actually is the dosing that to be used. Yeah, so for that particular points, typically we'll request a clinician, the ordering clinicians, to reference to the available clinical trial on the particular drugs or combinations. And let's say there's not any existing data is available, then actually it should be treated like a phase 1 trial. So you use it in a very conservative manner and monitor the patient much more closely. Yeah, so this is our experience with our collaboration with NUH and SGH as well.
Okay, so final wrap up, maybe to all our sponsors and all that. Thank you very much for your support for all these years. Now, moving forward, I guess some of you may not join us for our tomorrow's session, but we are going to move to China for our next few meetings, and we're going to slowly increase the size of the meetings to China likes to do it in a very big way. So we're going to include a lot of local delegates. So you'll like be 150 local delegates. It will be an expanded session. That means there'll be chances for spotlight sessions, for let's say, for example, like master classes or satellite symposiums on various selected things. So it will be a bigger, progressively bigger and bigger meeting. And we know that to engage your China colleagues, international, regional, and China is quite difficult. So we'll probably need more of your help to engage your local Chinese teams to actually then come together to kind of support the meetings moving forward. And there'll be also more presence like booths, exhibitions, and all that for interaction. So giving you fair warning that the next we're going to have a China meeting in Q3, Q4 next year, and we'll come up with that. Okay. Then, so with that, thank you again, sponsors. And our next session is our breakout session. Two quick questions, two quick comments. You all have been assigned your various working groups, but you don't have to stick to it, okay? Except for CLL. CLL renews, you cannot change. The rest you can change about. Number two is that although in person you can only attend one, but in actual fact, when they do the actual discussions and projects, you can actually join both, or 2 or 3 or 4, however many you want. Okay, so there's no limit that you can only have to do one. The more you do, the better. We hope that you can contribute. So you can be AML, ALL, CLL, and registry. Okay, and registry, we don't have a meeting because registry is going to be interspersed in all the groups and then gather all your comments. The 3 registry people are all in the 3 groups, one in CLL, one in AML, and one in AL. So you can give your comments and then they will then work together for that. Okay, so later you have the comments for the working groups. And the last comment before the working group is please have some action points because we are engaging the industry and various people. We need presence because our consortium is quite new. So we need publications, we need projects, we need to have, established our reputation as a group in order to have people join us and so forth. So please, when you meet, appoint your projects and appoint lead people to actually see it through. Don't just meet here and then after that forget about it and then next time meet again. Then we have no concrete stuff to show. So have like publications, projects, and stuff like that. So please appoint people so that you actually can have some tangible outcomes. Okay. Okay. With that, if not, then I hand over to Supon.
Okay. I think we have about 15 minutes coffee break outside, and then we will go right to the working group breakout.
Thank you very much, Mr. Cole, for conducting the latest session of the consortium today. And after this, we are going to have about 20 minutes break, coffee break. And after that, please proceed to the room that of your interest as follows. AML, you will be here. Remain in this room. ALL to the expectation room on the 3rd floor. And CLL, please proceed to the journey room on the 3rd floor. Okay. And please bring all of your belongings out of this room. Please bring it all with you because we need this room for the arrangement of the desk and the table for the next session. You may recheck your name and the venue of your next activities on the screen. And once again, another announcement is Since we are going to have the offsite dinner today, please be gathered at the lobby at 6 p.m. sharp for the offsite dinner. Thank you very much for your cooperation. And on the screen now, you can check your name, username, and the venue of the next activities of the breakout activities. Ladies and gentlemen, please bring all of your belongings together with you, okay? And after this, please allow the hotel staff to rearrange the room.